Hi everyone. I am an editorial fellow in Journal of Immunotherapy and Precision Oncology. Today we will interview Dr. Claudia Vieira, who is a medical oncology physician and researcher from University of Porto and Molecular Oncology Group Research Center. We will discuss her published paper in our journal called Pertuzumab in combination with trastuzumab and docetaxel in the neoadjuvant treatment for HER2-positive breast cancer. Greetings from Turkey, Dr. Vieira. Would you like to introduce yourself to us, please?
Thank you very much. I am a medical oncologist in Porto, Portugal, in a comprehensive cancer center, the Portuguese Oncology Institute. I work there since 2005, first like resident, and from 2011 like a medical oncologist graduated. I also have the opportunity, because we were close to Porto University, where I do my medical degree that continue after it during the residence of medical oncology. And then in 2019, I did my PhD in oncology, molecular oncology, working in the virology lab about the polymorphins of pain in breast cancer in patients with bone mets in breast cancer, because my main areas are the breast cancer and the head and neck cancer. And since I graduated I finished the residence, I only treat patients with that pathology. In the breast cancer unit, I have the opportunity to participate in this real-world data project. We usually in Portugal need very much of data, of real-world data and pharmacoeconomics to have a faster approval of the new drugs. So usually we do this monitorization in a service that we call the Outcomes Research unit with the epidemiology unit of the institute that also collaborated with the national data from the Portuguese cancer patients.
Thank you very much. We have learned a lot your published article. You are giving a lot of information about your real world data for the dual blockage HER2 treatment in breast cancer patients. Thank you very much for sharing us. And can you explain, please, according to your results, which cases should be considered for the pertuzumab plus trastuzumab treatment in breast cancer? And should it be considered for only high-risk patients or not, please?
So we usually treat patients according to the European Society guidelines that we endorse here in our cancer center. So more or less we treat with the neoadjuvant systemic treatment patients with tumor larger than 2 centimeters, or patients that we want to do a optimal surgery, a breast conservative surgery, but the breast is too small and we need the downsizing to potentially the surgery, or for the downstation with the axillary lymph node involvement. Here in this paper, clinical staging and the status of the hormone receptor were the significant predictors for PCR, so that patients had more benefits. The frequency of PCR was higher in the hormone receptor negative patients, which is in line with the previous studies. But in the whole population, the treatment of dual blockage group, the treatment with pertuzumab, have a great proportion of conservative surgery and a lower rate of axillary clearance. So that are positive findings, and we think that allow us to use in the whole population, like the guidelines of ESMO. However, this is a real old data with a small and consecutive sample size of patients. So there were the last patients treated with trastuzumab and the first patients treated with trastuzumab, pertuzumab, and chemotherapy. It was that idea to do a paper that have these clinical findings that we are presenting here, but they give rise to another paper of pharmacoeconomics that is published in Health Economics Review, a paper called The Addition of Neoadjuvant Pertuzumab for the Treatment of HER2-positive Breast Cancer, a cost estimate with real-world data. So you monitorize the drug for also that objective of the cost of the drug for our institution. So we have to be very careful with the lessons that we draw. We are now trying to put it more patients to have a bigger population, and because nowadays we are using more frequently the pertuzumab, and even now we have very few events to progression-free survival and for overall survival in these patients. These patients mainly they not have a recurrence since nowadays. So we have to be a bigger follow-up to understand the impact of this. Nevertheless, we are in a era of personalized medicine, and taking in account the high cost of pertuzumab, we think that it was important to publish these unicentric international real-world data to contribute to systemic revisions of multicentric data that allow us to understand better the variability of clinical benefits between subgroups.
Oh, thank you very much. In your trial, when we focus on adverse event in your trial, the most frequent adverse effect was anemia. And in the same line as previous the study, did you interrupt or stop the pertuzumab any patient from decreased LYEF as another important adverse effect? What is your opinion in your real-world data about these adverse events?
So overall, the side effects, adverse events, were very similar to that reported in the literature, the kind of adverse events that we find. In the pertuzumab cohort, the most frequent were anemia, diarrhea, mucositis, and leukopenia. But we only have 10% of grade 3 adverse events, where grade 1 and grade 2 has almost 87%, almost 88% in this group. We have an inclusion point where we said that we will only include patients who have complete the 8 cycles of anthracyclines and docetaxel. So maybe there we lose some patients who did another chemotherapy backbone because they have comorbidities or they were old age, and in the time to choose chemotherapy, we think that it was best not to do anthracyclines or have cardiovascular disease. So this is a group who complete all the neoadjuvant treatment and all the adjuvant trastuzumab. And we think that fact may have conditional low incidence of neutropenia and other hematological toxicities that are a little underestimated in this subgroup. For example, the use that we do nowadays, that we have the opportunity to treat many more patients with pertuzumab. And even if we put here that patients who did another backbone, maybe the results will be more close to the trials that give the approbation of pertuzumab. effectively, no major cardiac toxicity was recorded. The treatment tolerance was similar in both groups, with lower adverse events in the two groups. And we have only one patient in the Pertuzumab group that have a decrease in the left ventricular ejection fraction, less than 50% in the end of the adjuvant treatment. So only one patient have decrease of the cardiac function after all the adjuvant trastuzumab and also with the neoadjuvant treatment. We have a cardiology department very, very happy and close to us, that it was a team that worked very well. And if you have some doubts or if there are a decrease of 10%, they see the patient and try to improve with some beta blocker treatment or angioconversion inhibitor. So trying to optimize the cardiac function, and we think that it was a key for the success of these first patients, that we were very afraid that some toxicity was emerged. We all also participated in a clinical trial of Pertuzumab. So we were starting to use in this indication, but we have participated in Berenice, a neoadjuvant clinical trial of cardiac safety, and we are using the same measures to follow up the patients very close and to early treat cardiac toxicity.
Thank you. It is, we can understand after this explain. Thank you very much. The dual blockade HER2 treatment tended to have better pathological outcomes, but not statistically significantly in your real-world data trail. How you can explain it? Maybe it will be a good explanation for future directions.
Yes, that it was a point that we try to emphasize in discussion, because it was difficult to understand. We have, for all that I said previously, we have clinical trials, we have we think that we have the knowledge to start to use in the real world scenario. And when we were seeing the data, although a great proportion of patients have PCR when treated with Pertuzumab regimes, that was not statistically significant. The multiple variable regression analysis also suggested higher odds of having a PCR with Pertuzumab, although the regimen was not a significant predictor of treatment efficacy. The difference on the baseline groups, because they are not at the same time, may partially explain the results. So we should analyze this with some carefully, because that's is going to be. We think that in the future, if we have more follow-up, size higher, bigger, we'll have different results. We think that only times and events in this group will allow us to have that significant statistically that we don't have at this time. We believe that the complete pathological response will impact in progression-free survival and in overall survival. And if we increase enough this sample size, we will have a strength in the findings to evaluate Pertuzumab in the neoadjuvant setting. One thing that we put in the pharmacoeconomics paper was the cost. We have an average cost for the Pertuzumab patients of more or less 57,000 euros, accounting the 13, almost 14 were only with pertuzumab at that time, 4 patients. And each patient was 15, almost 16,000 euros of great cost when we put the pertuzumab. And that was clinical statistic to the PCR. So we at that publish, we calculated a score, ICER, that say to us that for 1 point of PCR, we need to spend 1,307 euros. Saying that way, 1,300 for 1 point, if we think that that 1 point will be more life savings, is not too much, we think, in Portugal. So we thought that that was the main conclusion of that work. Real world data, not statistical significant to PCR, but with a trend, not so expensive to the hospital in the end.
Thank you very much for your thoughts, all of this trial. And I like to be here with you and your experience about breast cancer patients. Thank you very much, Dr. Vieira, and your team.
Thank you. It was a pleasure.
Yeah.